Hello, I'm Dr. Azad from MedicoVisual.com, and in today's visual lecture, we will discuss a relatively easy topic in pH and acid base balance series, and the topic is respiratory acidosis. As well as in the same lecture, today's lecture, we will also discuss the respiratory alkalosis. So these two related topics will be taken up together. Now, in today's lectures, it is overall relatively simple topic, but one thing that I want to clear the concept in this lecture is that what happens in asthma. In asthma, there could be respiratory acidosis as well as respiratory alkalosis. If you open up any textbook of medicine or physiology, you will see in the topic of asthma or in the topic of respiratory acidosis and alkalosis, you will see sometimes the asthma sneaking into causes of both of these, but textbook do not mention the reason, and that I will do in this lecture as well, along with of course other things. So again, the basic idea, I will not repeat this, but you know that the acidosis is that pH is less than 7.35, but still I repeated anyways. So, and if pH is more than 7.45, that is alkalosis. That is simple definition of acidosis and alkalosis. Actually, it is simple definition of acidemia and alkalemia, and the pathological cause of this condition is acidosis and alkalosis. Now, today we will focus on respiratory acidosis and alkalosis. Now, the thing is that respiratory alkalosis or acidosis simply mean the cause of acidosis or acidemia or alkalosis or alkalemia is within the respiratory system. The cause is simply the respiratory, so respiratory cause. So if we talk about the acidosis, the respiratory acidosis, let's write it here. What could be the cause of respiratory acidosis? And we will also discuss what could be the cause of respiratory alkalosis. Now, the thing that you have to remember that in respiratory acidosis or alkalosis, either case, the factor that is deranged mainly besides pH, of course, that is PCO2, the partial pressure of carbon dioxide in blood. And PCO2, CO2 is basically an acidic gas. So for respiratory acidosis to develop, the PCO2 is high. PCO2 is high. And for the respiratory alkalosis, this acidic gas CO2 is low. So in respiratory alkalosis, CO2 is low. Of course, pH is less low in acidosis and pH is high in alkalosis. That you already know. So now, what can cause the rise in pH in respiratory, not pH, sorry, rise in PCO2 in respiratory acidosis, and what can cause the decrease in PCO2, the low PCO2 in respiratory alkalosis? If you understand this concept, it will be very easy for you to understand the causes of each of these. So what can cause the high PCO2? Well, if due to any reason, okay, let's first try to understand how the CO2 is excreted out of our body. Actually, the CO2 is generated by our different cells through metabolism, and then the CO2 is loaded on the hemoglobin and the red blood cells, and ultimately it reaches the lungs. And from lungs, then what happens in the lungs? From lungs, we have alveoli. Of course, we have our trachea, then bronchi, bronchioles, and so on. It divides and subdivides to narrower and narrower channels. Ultimately, it forms what we call as the alveoli, and within alveoli here there is the blood vessels here, and those blood vessels, the blood would be carrying CO2 and O2. So now the CO2 from the blood, it diffuses out into what? Into the alveoli here, and then from here it is then excreted out, exhaled out, basically, not excreted. The better word is exhaled out. Now, any problem in this pathway can lead to buildup of CO2. What could be the problem? There could be very narrow these pipes, the bronchi, bronchioles, they could be very, very narrow, right? And if they become very narrow, it would be difficult to exhale CO2 out and, of course, inhale O2 in as well. So hypoxemia plus hypercapnia may be there. Then there could be that these alveoli may be damaged, right? As in case of emphysema, the alveoli, their walls are damaged, right? And then in case of severe interstitial lung disease, or in case of pulmonary edema and different disorders, there could be the problem with this what is this exchange surface, not cervix, surface, exchange surface, right? So respiratory membrane or exchange surface, so surface not service. I don't know what happened with me, but anyhow, so the problem, so any respiratory disease can potentially lead to the respiratory acidosis, provided that it is sufficiently severe. A mild respiratory disorder may not lead to marked or severe or visible respiratory acidosis, but if it is sufficiently severe, then it can cause respiratory acidosis. Now, the point is that, and it is not just that, I have just focused on the respiratory system, but actually the control of respiratory system is beyond the lungs. That is even more important than this explanation. Who is the master controller of respiratory system? Our brain, the respiratory center. So message is coming from the brain, from the respiratory center, to respire, to actually to in the brainstem there are respiratory centers, so to fine tune and control the rate of respiration, that message is coming from the respiratory center in the brain. So now, due to any reason, if the respiratory center is depressed, respiratory center, due to any reason, if it is depressed, then it will lead to decreased rate of respiration, what we call as hypoventilation. This is the most important cause of development of respiratory acidosis. And what could be the cause? The cause could be any drug that depresses the respiratory center. For example, opioids, barbiturates, and there are several drugs. I don't even remember the name, but I hope you get the concept. Main point is not to enumerate each and every possible cause here. I want to make a concept in your mind, and then you can read any textbook or any reference, and it will definitely make sense to you. This is the whole point. Now, then of course, from the respiratory center, then respiratory muscles would be stimulated. Respiratory center is then not magically connected with respiratory muscles. There are nerves going on. So it means if the problem is with the respiratory center, then that can cause respiratory acidosis. If the problem is with the respiratory muscles, there is paralysis of muscles or weakness of muscles or any reason. So respiratory muscles involvement, the respiratory wall involvement, the thoracic wall involvement, then then the nerve damage of those muscles, nerve damage, or basically any reason that that causes the weakness or paralysis of these muscles, that can cause the problem with respiratory rate. It can decrease the respiratory rate, or it can make the respiration very difficult, leading to buildup of CO2. So this is the whole idea, that how CO2 builds up. Basically, it is hypoventilation, but it may not always be hypoventilation. For example, if there is severe damage to these respiratory membranes, or there is severe emphysema, severe damage to walls of alveoli, and diseases like that, there may not be significant hypoventilation, but actually the exchange of gases might be affected to an extent that it might cause the respiratory acidosis. Now, coming to the respiratory alkalosis, here the concept is that there is the excessive stimulation of the respiratory center, the regulator, right? Respiratory center. Now, what can stimulate the respiratory center? Well, a simple, not simple, that is also problematic, but severe anxiety or panic attack or something like that, psychogenic cause, that can even cause the excessive and faster respiratory rate. Even that can cause excessive washout of CO2. Along with that, if someone goes to high altitude, then this at high altitude there would be hypoxia. There would be risk of developing hypoxia, and to counteract that, our brain's respiratory center will be stimulated, and it would cause the hyperventilation. Now, this hyperventilation would correct somehow the oxygen, might actually correct the oxygen hypoxemia, but along with that, as a sort of side effect, it would also wash out the CO2, which might be previously normal. Then here comes the diseases like asthma that I wanted to specially discuss in this lecture. Now, asthma can cause respiratory acidosis as well as respiratory alkalosis, and it depends upon the severity of disease. Okay, let me explain this thing to you in very simple way. Now, in asthma, there is reversible narrowing or reversible constriction of the airways. So, what happens actually? Let's say if airway is like this normally, then in asthma, it might be like very constricted like this. So it means it will become difficult to inhale a sufficient amount of O2 as well as exhale out a sufficient amount of CO2. So the body would try to compensate it by increasing the rate of respiration. And increasing the rate of respiration actually would correct both, and especially hypoxemia, but it will also lead to hypocapnia. It will lead to buildup of CO2. The brain's respiratory center would try to compensate by increasing the rate of respiration, and that might fix the hypoxemia at least partially, but that might also lead to excessive washout of CO2, leading to hypocapnia or CO2 loss, which might cause respiratory alkalosis. But why alkalosis? Let me explain this thing to you. The idea is that there is a difference between the oxygen dissociation curve. So if we draw the oxygen dissociation curve, this is, let's say, the partial pressure of oxygen, and this is percentage saturation. Now the oxygen saturation curve looks like this. Oxygen saturation should be normally above 90%, right? So oxygen saturation is somewhat here. Okay, here more than it's about like 90%. So it should be 90% or more. Better is more than 92%, right? So what happens if, let's say, it becomes low, and let's say it arises to, let's say, maybe 80%, let's say, or 85%. Okay, 82%, just arbitrarily I am mentioning it. So now you see how the graph looks like. So it means if it is here, this is the PO2, that is the partial pressure of oxygen, let's say, within the alveoli. If it is here, now if there is hyperventilation, the partial pressure in the alveoli might increase, and this increase from here to 1, 2, 3, 3, 4, and 5, 6, 7, 8, and 9, up to here. So up to this point, up to 9 points, if we walk from here up to here, if we walk up to 9 points, don't worry about the units for now. I am just showing you arbitrary values to make you understand this concept. Let's suppose here you are walking 9 points to make the O2 normal, but at the same time, if you look at the graph of CO2, it is vastly different. It starts like this somewhat, and then it is slightly like this, but it is mostly like sort of linear rather than sigmoidal. It is mostly linear like this. Let me draw it in a better way. So it is like this sort of. So it means if we CO2 would decrease, of course, as we exhale out. So if we move 9 points here, 1, 2, 3, 4, 5, 6, 7, 8, 9. If we come here, 9 points here, you see, and we are like here. Now you see that this is the height that we would have traveled. So we would have lost a lot of CO2. But here we have gained a little O2. So little bit of O2, if we get extra O2, little bit of O2, oxygen in the blood, while doing so, we are losing lot of CO2. This is the main problem. This is the main problem. This is just like that. You might have seen in hospitals the stairs, they are not steep, they are like quite flat. They are like this maybe, or maybe like this. But if you go to some malls or some other places, the stairs are like this. So if you want to reach the same height, you will have to walk less here. In this direction, you have to walk less here. But in this direction, you will have to walk more in these type of stairs. This is the case here. You know, these stairs, these are like less steep. You have to walk more to reach this level. But here, if you walk little bit on the x-axis, you will fall a lot, right? So this is the main problem, that while correcting a little bit of O2, you are losing a lot of CO2. So in asthma or any other similar disease, even in high altitude sickness as well, you are trying to gain a little bit of O2 in the blood, and while doing so, you are wasting, you are getting rid of lots of CO2. That's how their graph is. And I will not go into these reasons. Basically, there is the specific hemoglobin structure, the, I forgot the name, the cooperative binding. Yeah, there is the concept of cooperative binding. But CO2, its dissolution or dissolving phenomena is quite different. These things we might discuss in the respiratory physiology or in the hemoglobin biochemistry, but not in this lecture. But you just understand the reason, the basic idea for this. Now, Asthma, if not severe, if not very severe, or if there is acute flare up, especially in milder cases, in acute flare up, that is likely, that might likely cause the acute respiratory alkalosis. But if this narrowing is very, very severe, or if the asthma is too severe that patient's effort is like lost and it is the asthma is prolonged, patient effort is lost, patient is tired up, right? A patient cannot respirate at very high rate, hyperventilate for too long. So that might actually lead to, in severe cases, might actually lead to respiratory acidosis. So both can happen. And in very severe cases, if there is first respiratory alkalosis and then there is respiratory acidosis, uh, intubation might be needed, right? So that is another important clinical point. But the point is that both can be there depending upon the severity. There is a disease called COPD which is more severe, and in that there could be irreversible constriction or narrowing of blood vessels. Along with that, there could be emphysema. Both of these things are usually coexisting. In emphysema there is destruction of alveolar wall. So when both things are coexisting, in those cases, acidosis is more likely. In those cases, respiratory acidosis is more likely as compared to respiratory alkalosis. Now, how would this acidosis or alkalosis, how would there be compensation for that? How would they be compensated? Well, when there was metabolic acidosis or alkalosis, it is actually compensated by respiratory system, but here the problem itself lies within the respiratory system. So compensation cannot come from the respiratory system. Compensation would definitely come from the renal system, but before that, the immediate first line of defense are our pH buffers. And pH buffers mainly that work here is the intracellular buffer, the hemoglobin buffer. Any protein, they can bind the proton reversibly and release them, and that's how they work. I have a complete separate lecture on pH buffer. That is why I am not going into detail in this lecture. Otherwise, it will become very long lecture. So yeah, that is the main idea. And of course, renal compensation, kidneys would try to, in case of acidosis, kidneys would try to retain alkali reserve bicarbonate, and in case of alkalosis, kidney would try to get rid of the alkali reserve. And there is a concept called acute respiratory acidosis or alkalosis. And then there is a concept of the chronic respiratory acidosis and alkalosis. What is the difference between them? The difference lies in whether the compensation, the renal compensation, has taken place or not. So renal compensation takes time. It may take up to 36 to 48 hours to even begin, right? So it means that immediately after the respiratory alkalosis or acidosis has started, it means the bicarbonate level would be near normal, near normal. But after some time, as the renal compensation start, then the bicarbonate level would be high or low depending upon whether it is acidosis or alkalosis, as I mentioned. So that is chronic respiratory acidosis. Basically, these are just the fancy names of respiratory acidosis with compensation, with renal compensation, just a fancy name of that. I hope you got the point. So this was all about the respiratory acidosis and alkalosis. Thank you so much for watching this video. Have a great day. Goodbye.